This is our sixth session in our migraine discussions. My name is David Kernick. I'm the headache lead at the Royal College of General Practitioners, and I'm with Professor Macgregor and Alison Frith at the City of London Migraine Clinic. And in this session, we want to talk a little bit about preventative medication. We looked in our last session on how you treat the attack of migraine, but clearly in many cases, that's not going to be adequate for suitable control. So I guess my first question is, Alison, when do we start preventive medication?
There's no hard and fast rules. You don't have to have a headache every day or even every week, but if your headache is causing you to lose time out of your life, then it may well be worth considering. So if your headaches are not responding adequately to treatment, then that may be worth considering taking a daily tablet to see if you can reduce the severity as well as the frequency of attacks. Not everybody wants to take a tablet every day, but there is a place for sometimes breaking a cycle of severe headaches.
So what you're saying is there's no real hard and fast rule, it all depends on the patient?
It depends very much on the individual person and their attacks and their willingness to consider adding in more medication.
Yeah. I mean, some people might just get one migraine attack a month, but that really knocks them off their feet and they really want something to prevent that.
If it lasts for 4 days and it's every single month, then that may be worth considering.
Yes. And I wonder if you could just talk us through what drugs are available. And I think it's true to say that all these drugs for the prevention of migraine have been found what we call serendipitously. They've been found totally by chance. Someone was taking a drug for their blood pressure and they thought, golly, my headache's better. So whereas the triptans were designer drugs designed specifically for the migraine biochemistry, all our preventive drugs were found by chance.
That's right. I think the only two, if I can think of the only two drugs that are solely licensed for use in migraine must be pizotifen and methazergide, probably, both very, very old drugs. I think what we try to start with, well, first of all, we inform people that no preventative treatment is going to totally take their migraine away. And it's very important that they recognise that they will still need to take acute treatment as well. The simplest ones that we start with are a class of drugs that people recognise as antidepressants. They're called tricyclic antidepressants. And people are always very worried when we mention the word depression and sort of think that we must think that they're terribly depressed. But this class of drugs, one of which the common one is amitriptyline, is used across the spectrum of medicine for pain control. It's very effective. So if you've got back pain, if you've got jaw pain, if you've got migraine, these are very, very useful drugs. So that will tend to be one of the first ones we'll start with because it's very safe, very effective, and works on many people. The other serendipitous one that was found was a beta blocker, or the group of drugs called beta blockers, which are more commonly used to control high blood pressure. And as you mentioned, people who were taking beta blockers for high blood pressure reported that their migraines also improved as well. We tend to use lower doses for migraine than is necessary to control high blood pressure. So again, we have a very good set of drugs that are very well tolerated with very few side effects. Stepping up a bit are groups of drugs called anti-epileptics, which have been more commonly used for epilepsy. And the one most people may have heard of that's recently been licensed for migraine is topiramate, but we do also use another one called sodium valproate. I think what other drugs we use at that level?
Well, pizotifen or Senna migraine is the other name for it. Do you find that helpful in practice?
Actually, we tend not to use that one so much now because people do find that it makes them a bit sleepy. Mm-hmm. And I think women often aren't keen on having drugs that makes them more hungry and can put on weight. Mm-hmm. People tend to come and ask for us for drugs that, you know, what are the ones that are most likely to lose weight or at least not to gain weight. Right. At the top level, we're talking about, you know, some odd groups of drugs that may be prescribed at a specialist level, some different pain control drugs, some other anti-epileptic drugs that are used, and perhaps even the one I mentioned earlier, methazergide.
But from the perspective of general practice, beta blockers, the amitriptyline and the anti-epileptic agents, sodium valproate and topiramate should be well well used.
And are probably underused.
Yes.
I think people are afraid about side effects. It again comes back to information. I think people often think that when they're put on a migraine preventive drug, that's it, they're going to be on it for life, which is just not the case.
That begs the question, how long should you be on a preventative drug for, first of all, before you judge whether it's working or not, and secondly, how long should you be on it for if it does work?
I think the feeling is we will tend to start with, well, our practice here is to start with low doses, which may be too low for effect, but we will try to get people to find whether they can tolerate the drugs. So if they're not getting unpleasant side effects, but they're not getting any benefit to their migraine within 2 to 3 weeks after starting a preventive treatment, then we will increase the dose. So it's building that dose up until they either experience intolerable side effects and have to stop it, or they're at a dose, the lowest effective dose that is making a difference for them. Once they found a dose that works for them, then we will recommend that they stay on that dose for around 3 to 6 months. And that is just to break the cycle of their migraine. So there is evidence from research studies that shows if you stay on a preventive treatment too long, you can actually build up unwanted side effects that can make you feel just as bad as when you were having more frequent migraine. So the aim is really to stop it, and once you stop a preventive drug, that means that the benefit that that person has experienced is often maintained.
But there are some people that need to be on preventive drugs long term. We have to accept that.
That's true, but I think you can only find out those people by trying and seeing what happens when you reduce the dose.
Yes.
And it's important when people stop preventive drugs to actually reduce the dose gradually.
Yes.
Because if you stop a drug too quickly, they'll just get a rebound migraine and think that they need to continue on it unnecessarily.
Yes. And I tend to say go on the highest dose you can tolerate, as you said, but for at least 6 to 8 weeks, because I think so many people say, oh, I was on the drug, and how long are you on it for? 2 weeks, and they stop it, and really you haven't had any time to detach.
2 weeks is far too short, and it may not be 3 months until they actually really start to achieve.
We have so many people that come to the clinic and say that they've tried all different kinds of preventatives and none of them have worked. But when we actually speak to them, they've only tried a drug for maybe a couple of weeks before giving it up, not really giving it a fair chance. So it's important to realise that none of the preventative drugs are a quick fix.
Yeah.
And also not understanding or not being informed that things may get worse before they get better.
Yes.
So within those first couple of weeks, they may actually feel quite sedated, a bit nauseous, have a dry mouth, not feel it's doing any benefit on the migraine, particularly with something like amitriptyline, which we know won't even start to kick in until they've been taking it for at least a couple of weeks. So understanding how the drug works and what side effects they might experience is very important.
Right. I wonder if you could just go back a bit to medication overuse headache, because clearly preventive medication is one of the things we have to bring on board if people are suffering from medication overuse headache. Inevitably they have medication overuse headache because they're having frequent migraine, which then they take more and more painkillers for. So one of the things we have to do is get them off this frequent painkiller and get them on preventatives. What's your approach, Alison, in clinic to this? Do you stop them suddenly, or how do you get them off their painkillers?
It varies very much between patients and depends on what medication they're using to excess. And this is where the diaries come in. We encourage people to keep diaries, to be very honest about the medication that they're using. The best way is to stop all medication straight away. But what actually happens is that people can feel worse than ever when they stop their medications. Their headaches can be even more painful and more severe. So that's not always an option. So for different people, sometimes we add in a prevention medication at the time of the drug withdrawal. We also use courses of non-steroidal anti-inflammatory courses to help support the patient during what can be actually a very turbulent few weeks while they're withdrawing from drugs.
And it's important, like stopping any addictive medication or smoking, it's choosing a point of when you can stop. Obviously, if you've got a big event on at work or something in your life that's happening, it's not a good time to stop, because it's not going to be easy, is it?
I think many of those people are afraid that there might be some more sinister cause to such frequent headaches. And once it's explained to them that the medication that they're taking may be actually provoking the headaches, they feel far more comfortable about picking their time to actually stop taking the medication, because we can explain to them it's not actually going to get any worse, but it's just not going to get any better. But people often feel very guilty. They feel that they've brought the headaches on themselves, that there is this sort of feeling that we're almost chastising them because they've got these headaches. And I think people need to be aware that we really are clear that it's through no fault of their own, because the natural thing that people are told is when you have a pain, you take something to stop the pain. So why should anybody recognise in themselves that taking those painkillers regularly is actually generating more pain for them?
We don't really understand the mechanism of what's going on in the brain.
We don't understand the mechanism. I think in simple terms, one can explain that the body is very good at making its own natural pain control. And when you take intermittent painkillers, you know, maybe just once or twice a week at most, then those painkillers are adding on to the natural pain control that your body makes. However, if you start taking painkillers more frequently, the body may think, why do I need to make any pain control myself? Because it's all coming from the outside, which means that the individual has no internal pain mechanism to control that pain, so that when they don't take a painkiller, the body feels more pain. And I think we're aware that people who are in that state of the daily headaches from frequent medication use also experience a lot more other pain as well. It's not just headache.
Okay. A lot of people don't like taking drugs, and there are a lot of things available that you can buy, what's called natural agents, butterbur, feverfew, coenzyme Q10, magnesium. What do you feel, what's your approach to these medications? Do you recommend them? Do you discourage them?
I think it's again back to finding what works for the patient. It's back to exploring with that individual what way, what type of management that they want. And then if people say to us, I don't like taking drugs, we can then explain to them that there is research that shows that things like coenzyme Q10, magnesium, the butterbur are effective, but that those trials have only been done in a limited number of people, and that quite often we've got no safety evidence for longer than the 3 months duration. So particularly for something like vitamin B2, the riboflavin, where the dose is actually 200 times the recommended daily dose, 20 times the recommended daily dose. We do need to be careful that we don't know any long-term effects it might have if people take it outside the length of the 3-month trials that we have evidence for.
And of course there are a lot of other approaches, acupuncture, homeopathy, psychological approaches. People spend a lot of money on these things. Alison, how do you feel about all these other complementary areas?
For some people, these areas can work very, very well. I would always say to people to speak to the therapist that's providing the treatment to get an idea of how long the treatments will last, so that you're not spending lots of money month after month with no benefit. Sometimes you can feel worse before you begin to feel better with something like acupuncture. So it's having an open relationship with the therapist, and it may be worth trying to see if it helps you, possibly in conjunction with conventional medical treatments, prevention at the same time. May be worth a try, but not to part with lots of money.
And any thoughts on the complementary therapies?
Similar to Alison's really. I do worry that people do get caught up spending an awful lot of money on treatments with no good evidence. Having said that, migraine is such an individual treatment that you need to get back to finding what works for that person. And clinical trials will tell you what works in a large number of people, but it won't tell you what is going to work for any individual within that.
I think it's a really important point. We keep on coming back to everyone is different, and trials tell us what happens in big groups of people. It says nothing about the individual. And I think that's a really important point. Okay, well, thank you for that. We're going to move on in our next section to talk about some features of migraine in women. There's some special features in women that we need to think about, and we'll be looking at that in our next session.